Many of you are probably wondering why the Kardashians. Well, there are several reasons. First, they seem like a natural follow-up to my December presentation, which featured an alien theme. Second, they seem to have created a serious value proposition campaign, and though I don't buy into it, I have to admit it's been pretty powerful and sustained. Last summer, I admonished my college-age daughter for wasting good time watching the Kardashian show. She retorted that I should be using them as an example to my clients about effective branding and marketing positioning. After some research into the Kardashians and their empire, I had to concede her point. But for the love of heaven, don't ever tell her that. The third point, and again, while I don't subscribe to the Kardashians or their empire of diverse products, my attitude pretty much toward them is, what's the point of it all? But they seem like a metaphor for the mindset of some healthcare organizations and their attitudes towards community-based services. So here we go. I just want to quickly review some of today's objectives. We're going to highlight the objectives of integrated care initiatives in alignment with community-based organizations, because that's pretty much what's driving a lot of the changes that you see in healthcare. We're going to talk about value proposition and what does that mean broadly and specifically to community-based organizations like yours. We'll review key integrated care drivers for various healthcare organizations, discuss alignment of nutrition services and products to healthcare organization needs, and we'll try to figure out if we can capitalize on the Kardashian mojo. And while we won't be crafting your marketing materials today, this information should provide good fodder for further local research into your potential customers' needs. Speaking of customers, I'm using this term to represent the healthcare organizations to whom you are targeting your sales pitch. Enough said here. I was surprised in my research to come across last year's Time magazine top 100 influencers in the world, and Kim Kardashian was there with a foreword from Martha Stewart. I thought that was very interesting, or a sign of the apocalypse. I can't decide which. The term value proposition is a regularly utilized term, but it has very diverse perspectives depending on your audience. For purposes of this session, your value proposition is the messaging and outreach process that will be developed to research your customers' needs, evaluate your organization's capacity to meet said needs, and the development of the outreach campaign you'll utilize to sell your services. Does the term sell sound discomforting to some of you? Well, it's part of the brave new world of integrated healthcare delivery, so you better get used to it. The primary driver behind the cataclysmic changes in community-based and traditional healthcare delivery is the Accountable Care Act's focus on integrated care services, especially between Medicare and Medicaid paid-for services. But it's reaching far beyond these parameters. In the highlighted lines above, I've emphasized the role of community-based organizations in this brand new paradigm. And, you know, for purposes of community-based organizations, I hear a lot of pushback from folks, and even from the health plan side, that, you know what, this new catchphrase integrated care is going to go away in a few years. But I'm going to borrow from another campaign. It's here, my peers, get used to it. Some of the elements of integrated care, especially as defined by the Centers for Medicare and Medicaid Services, focus on person-centered accountable care, multidisciplinary teams providing care management and coordination, and this is a big change for you, your organizations, and for the healthcare arena. Comprehensive provider networks. Here's an opportunity for you to become part of a health plan's provider network, which are being very finely detailed in upcoming Medicaid and long-term care legislation. Enhanced use of home and community-based long-term care services. I think that statement speaks for itself about the opportunities that are inherent in the ACA's integrated care positioning. Strong consumer protections, again, a big emphasis on consumer choice, person-centered planning. Robust data sharing, this is another place where there are some challenges on both sides of the aisle for healthcare plans and how they communicate and share data with community-based organizations and vice versa. This is a big opportunity for community-based organizations and or challenge to ensure that they are ready from a data sharing and reporting perspective to get engaged with these new customers. And then, of course, the financial alignment that blends Medicare and Medicaid funding and the multiple rules surrounding that. The implications of, excuse me, integrated care, again, on both sides of the aisle, for community-based organizations and as well for the healthcare community, is that if these objectives are to be met, there has to be a broader engagement between the traditional clinical and community-based care. This coordination is critical to the well-being of both these entities' mutual clients, the consumer. If, in fact, we are going to be very consumer-focused, it becomes critical to understand that in many cases, these integrated care programs move the consumer into these healthcare organizations, whether it's accountable care organizations, Medicare Advantage plans, dual eligible, excuse me, demonstration health plans. The health plans tend to be the drivers, and our responsibility and role as community-based organizations is to figure out how we fit in to their paradigm, how we fit into their structure so that we can continue to provide the very critical care that's necessary for the safe and sustainable care of our consumers in the community. One of the other principles of the Accountable Care Act and the integrated care is a discussion of something called triple aim. And if you look at triple aim, it has these three primary elements. The patient experience, which is about person-centered care planning, the ability for consumers to remain healthy and sustainable in the community with proper supports and high levels of patient satisfaction. The population health piece comes into play as we talk about the emphasis on healthcare outcomes and improvement, not necessarily the process piece, which has been a very important part of how the clinical side of the healthcare continuum operates. It also looks at the use of evidence-based programs to support quality of care and a higher level of preventative engagement. And then finally, cost. It's always all about the Benjamins. Ultimately, through the effective implementation of the aforementioned practices, the cost of overall care will decline or should decline due to hospital inpatient, emergency room, and readmission reductions, and the reduction of institutional care through increased community-based living and services. So let's talk about these new customers. For purposes of this presentation, we'll be focusing on hospitals, health plans, and providers. And whether it's contractual, regulatory, organizational mission, profit and loss, or any of many multiple factors, you need to understand clearly and carefully what motivates your potential customers and how your solutions to their problems or needs can positively impact them. One of the challenges that I've shared with other community-based organizations when I've done these kinds of presentations is I can provide you with some very generic information about what are some of the drivers for these various entities, but it's incumbent on you to understand what are the very specific local issues around these broader categories. If, for instance, you've got a Medicare Advantage plan in your community whose star ratings, and I'll talk about that in a moment, are at risk, you need to understand that they may be losing their Medicare contract or their ability to contract with Medicare if they can't improve their star ratings outcomes, and then your job is to figure out, having knowledge of that information, how do your nutrition services and supports potentially impact their star ratings outcomes. So let's take a quick look at some of these key providers. Hospitals. Their drivers start with their contracts. They're contracted with Medicare, they're contracted with Medicaid, they're contracted with the Blues, with Aetna, Humana, WellCare, and the list goes on and on and on. And none of those contracts tend to be the same. And in many cases, hospitals have 14 different Blue Cross contracts, 22 different Humana contracts. And so the ability to understand how those hospitals need to meet contractual obligations becomes an important part of how do you approach them. I can help you meet your customer hospital, the Aetnas, the Blue Crosses, the Medicare. I can help you achieve and attain the goals that they've laid out for you. Medicare payment rules and just Medicare in general is such a convoluted and confusing scenario, but Medicare has become very proficient recently at defining specifically what they're looking for in terms of hospital outcomes. For instance, a big driver per the Accountable Care Act a few years ago was 30-day readmissions to hospitals. So hospitals are potentially financially on the hook if someone who is discharged and meets certain criteria is readmitted for similar reasons within 30 days. That next day, they may not be getting paid for. So hospitals may be looking for some intervention from organizations like yours to help them with some of the post-discharge planning that occurs so that they can keep these folks at home and out of the hospital. So do therapeutic meals, if that's what your bailiwick is, can you support discharge planning and community well-being through the delivery of therapeutic meals? Do the hospital administrators in your community even know that you provide that service? Does somebody need a liquid diet? You can provide those kinds of services. That's the kind of thing that you can help a hospital understand. 30-day readmission reduction, I've got a solution for you. Accreditation is another huge accreditation. It determines whether or not they can contract with certain organizations, and it may in some cases determine what their pay rates are. A big part of that is patient outreach and satisfaction. The accreditation process relies heavily on patient input. Is there a high level of patient satisfaction with services or not? Sometimes that post-discharge experience from the hospital gets factored into how consumers perceive their care was. And you'll recall earlier in a slide the discussion oh, pardon me, I'm so sorry. The commentary about the triple aim and that patient experience. This is where that patient experience ties in to a hospital. And again, the cost. 30-day readmissions potentially cost hospitals. Poor accreditation outcomes potentially cost hospitals money. Health plans, the broad array of health plans that are out there, whether you're talking about Medicare Advantage, Medicaid only, dual demonstrations, commercial health plans, etc. The accreditation process determines in many cases, again, whether or not they can get certain contracts. It may determine what rates they get paid, what kind of members they can enroll. How do you help support, again, through that member engagement, consumer engagement, their outreach and satisfaction through the delivery of services that you provide that reach out to those members. Contractual obligations, for those of you who are participating in states where dual demonstrations or Medicare Advantage, Part D SNP programs operate, you understand that there are numerous contractual obligations to reduce institutional care, to reduce hospital admissions, to see improved wellness outcomes, enhanced preventative services. You have the ability through your network to support some of those positive patient outcomes, and certainly as you are looking or your staff are eyeballing folks every week, you also have the opportunity to help increase health organizations' engagement in preventative services. You deliver meals. Mrs. Jones's meals are stacking up on the porch. You have an opportunity to coordinate between the primary care physician and perhaps a case manager to say there's something going on there. You might need to get a nurse or your care manager out there. The providers. Providers are delivering care for a myriad of organizations. They could be contracted directly with Medicare fee-for-service, Medicaid fee-for-service, commercial fee-for-service through Blues, and they also have myriad contracts with healthcare organizations. Many provider organizations, or those multiple provider groups, are under contract or are under accreditation called primary care medical home. Those accreditation standards are pretty high and require, again, huge engagement and rely heavily on consumer outcomes, consumer behavior, and consumer satisfaction. Here again, with the primary care providers, post-discharge planning from the hospital should include the provider, the hospital, care managers, and potentially organizations like yours to coordinate the development of that post-discharge care plan in conjunction with the member to ensure that readmissions are reduced, because the providers end up getting penalized as well when their patients are being readmitted frequently, when their patients are not meeting some of the screening requirements such as diabetes, the A1C, the eye exam, etc. You can provide support, again, through your encouragement in a one-on-one relationship with members that, if Humana says to you, I've got these 13 members who need to get their HbA1c screening done in the next 30 days, as you're delivering meals, a reminder to them to contact their primary care physician might be beneficial to both the primary care physician and the health plan. Providers are tied into the whole integrated knot of performance outcomes and pay for performance. And so as their patients' outcomes improve, they can earn bonuses. You can help contribute to the earning of those bonuses. And again, the cost effectiveness. Providers are at risk in many cases for how their patient outcomes look. Whether they're getting paid on a fee-for-service basis or a capitated basis, there are bonuses tied to performance outcomes and your ability to suggest that you have the opportunity to help keep people in the community, to help reduce inpatient care, to help improve health outcomes through nutrition support could resonate with providers in your community. And I'd also suggest that you look not just at privately established providers, but the federally qualified and rural health centers in your community would greatly benefit from some engagement, and in many cases they're looking for partners to help them with some patient outreach, especially for providers and for health plans with hard-to-reach members. You know that many of the Medicaid population on a national basis, about a third of them, excuse me, it's a very transient population, and about a third of all Medicaid folks on Medicaid move within a 60-day period, and health plans don't know where they are, the social services workers don't know where they are, but you tend to know where they are, so you help them reach those hard-to-locate clients and enable them to maintain contact and engagement and support preventative engagement. The accountable care organizations, when you think about some of those organizations who are in partnership, generally a three-way partnership with providers, hospitals, community-based organizations, and some others, to help reduce what Medicare considers exhaustive hospital inpatient stays. And these ACOs are targeting just that, to really focus on a reduction of inpatient stays, a reduction of ER, and each ACO may have some additional goals or mission added to their positioning. So one of the opportunities, again, is the performance and quality outcomes. How can you help reduce inpatient stays? How can you help reduce overall patient improvement and wellness through nutrition services and support? Again, the cost effectiveness of how you serve and provide these services, and by no means am I suggesting that you bill them the same rate that you're getting paid by the state through your state funding or your federal funding, but you generally can do it at a more cost-effective level than some of your competitors might be coming in. And I do want to, again, advise that there are competitors coming in to fill these gaps in the community. And again, the whole focus on the hospital and ER reduction is kind of the cornerstone of what the ACOs are about. When you think about, though, the preceding discussion and What are the drivers that are influencing these healthcare organizations? And then, well, what the heck does that have to do with nutrition services? Well, we're at that slide now. Consumer engagement. I've broken it down into 3 primary functions, but I'm sure as you go back to your organizations, please consider this just fodder to get that conversation started or to advance the conversation. Pardon me. Advance the conversations that you've already had. If you look at it in these 3 primary categories, though, it makes it a little bit easier when you need to focus and kind of pinpoint where do I plug in how nutrition services impact these different organizations. And the first one is consumer engagement. And I've listed a couple of factors here, many of which I've already commented on, but one of them that's very important to understand is health plan administration, whether it's an insurance company like the Blues or an HMO like Humana, Medicare, fee-for-service, Medicare, Medicaid, or Medicare fee-for-service, very few of those entities actually ever see the client. You do that every day. The value that that provides in terms of identifying potential issues, the early intervention for appropriate preventive care, those are very, very critical to how some of these organizations are going to achieve these lofty goals and these financial goals and quality goals that are inherent in their contracts. Medication reconciliation. Under the Medicare STARS evaluation system for Medicare Advantage plans, medication reconciliation is a huge part of that. And depending on the scope of your organization's nutrition services, your engagement and support of identifying that somebody's taking their meds or they're not could be a huge factor, again, in some of those quality outcomes. Consumer satisfaction and retention. Happy consumers tend to remain with the health plan or the hospital system or what have you. Unhappy ones tend to walk at open enrollment. Your ability to help contribute to the overall satisfaction of that health organization's services and supports through your engagement with the consumer could be a huge factor for them. Another piece that was brought up is the community needs assessment data, particularly important for those Medicare Advantage plans that have special needs plan designation, the D-SNPs, the I-SNPs, and the C-SNPs. They're required to collect information on population health in their communities that gives them some sense of what are the primary health care conditions, what are some of the primary barriers to services and access to care in the community. Your community needs assessments that you present every year have great value to these organizations, and sharing them might be one of those entrees into the organization that would be valuable for you. From performance outcomes, you have the potential to increase access to preventative services, again, because you're seeing the client. You know that if on Monday Mrs. Jones was spry and on Wednesday when you went back she seemed a little out of it, disoriented, you have the ability to feed that information back to the hospital or the healthcare organization, the caseworker, case manager, whomever, and help them get engaged with the client in a much more faster response. And generally, the organizations tend to find out that the person's health care is declining because they show up in the emergency room or at the hospital. Your ability to help them get engaged before that point is very critical. Under the care coordination, again, the nutrition counseling support and services, your ability to convince these organizations that you need to be part of the care planning, the integrated care team, or the ICT as integrated care programs spring up. Your ability to provide those nutrition counseling and that nutrition therapeutic meals, etc., it could be great value to these organizations. And you know, your registered dietitian expertise is just very, very critical for these integrated care teams, because very few care plans for persons with chronic illnesses, the frail elderly, very few of them, or almost all of them, tend to have some heavy nutrition component, and you can be a major contributor there. I certainly, under the Medicare Advantage reform, I think of 2009 or 2007, Medicare introduced a new level of Medicaid, a new level of Medicare Advantage plans that are specific to managing the chronically ill population who had traditionally not been engaged in Medicare Advantage programs because they tended to have Medicare and Medicaid. And before that, there was no real structure for the integration of Medicare and Medicaid services. So D-SNPs are those programs that focus particularly on dual eligible people who have Medicare and Medicaid, and they have some very specific rules about how they have to integrate the Medicare and the Medicaid services and coordinate between the feds and the state for delivery of these services. But it's not the same thing as an integrated care program, which is a whole nother smoke. But many of the integrated care demonstrations or dual demonstrations are being run through certified D-SNP programs, and the D stands for Dual Special Needs Plan. So the SNP, SNP, is Special Needs Plan.
Too many abbreviations in this world, right?
It's Medicare, it's healthcare. And I have a slide that talks about that. So the I-SNPs are called institutional special needs plans, and there aren't as many of them, and they deal with people who providing coordinated and managed care for people who are institutionalized in nursing homes and other organizations like that. Then the final one, the C-SNPs, stands for chronic care, and those tend to focus on those chronic care SNPs tend to have a single disease focus. So Fidelis, if any of you are familiar with Fidelis organizations in your community, Fidelis tends to operate a diabetes-focused chronic care SNP. So those are, again, different kinds of Medicare Advantage contracts that entities can engage in to provide coordinated care and services to a Medicare population.
Great, thank you very much.
You're very welcome.
Somebody in New York, William Lane, who says that a number of the AAAs in New York State have contracts, and so that's an interesting. Thank you for sharing that with us, William.
I would say that New York, Michigan, Ohio, California, Minnesota, South Carolina, North Carolina, Tennessee, and there are about 13 states in the country that executed the original dual demonstration contracts. And so they have, at least in those 13 states, Massachusetts being one as well, they are not necessarily under a mandate, but they've been directed to coordinate and collaborate with AAAs and other organizations to provide some of the managed long-term care services that are part of the dual demonstrations. You should also note that a number of states may dictate that the AAAs are going to be the screening or the primary entity assisting with enrollment of people into these various health plans, in which case you cannot contract with those health plans to provide direct services. So what some AAAs have done is establish separate entities, whether it's an LLC or another 501c3, and that entity then can provide the services to the health plans, while the AAA specifically is that no wrong door entry and enrollment function. So that's just another aside, and maybe another session we'll have down the road.
Right, exactly. Thank you very much, Sharon.
It's critical, just as these very, very important questions that you all have raised, excellent questions, perfect lead into this next slide. You have to understand and speak their language. You need to understand the culture and the business environment. Understand, I've given you, again, general broad categories, accreditation, consumer engagement, performance outcomes, but you need to understand and narrow it down through your own continuing research. What are the key issues for the entities you're going after under those broad categories? And understand that they're ever changing. The healthcare environment is incredibly dynamic and always open to interpretation. And in some cases, depending on who the state administration is or the administration is at the federal level, one day it's all HCFA 1500 forms have to be done on pink paper. Change of administration, it's got to be blue paper, and you got to be able to turn around on a dime and be able to respond. Not only do your customers have to respond to those dictates, but you have to be ready to support those dynamic changes. You need to define your solutions in terms of what is meaningful to them. What's their nomenclature? What is the terminology that they use? And you have to be prepared to design multiple value propositions for multiple audiences within a single organization. Again, as part of your continuing research, you need to find what are the local issues that resonate with your customers. For example, a review of the Joint Commission on Hospital Accreditation Standards by someone in your organization can provide key insight on issues for hospitals regarding their accreditation process and the consumer's huge influence on same. Your understanding of how your organization's post-discharge consumer engagement and its potential impact on what's HCAP, those are the hospital consumer review surveys, how do those scores impact and factor into your value proposition? Accreditation is also critical to hospitals' abilities to, again, secure and maintain contracts, etc. If you think about another example, and I think I touched on this a little bit earlier, is the Medicare Advantage plans and the importance of meeting the STARS rating criteria. Every plan is evaluated every year on, I think there are 55 elements in 11 categories on the STARS survey. And it includes things like medication and therapy management, consumer satisfaction, falls prevention, event intervention, and preventative services. And the STARS ratings determine what a health plan's Medicare reimbursement is going to be. It also gets published and is utilized to determine if 5-star plans, consumers, no matter if you understand Medicare Advantage or not, 5 stars are better than 2. If you're an informed consumer, you're probably going to pick the 5-star Medicare plan. And, excuse me, plans that don't retain at least a 3-star rating are subject to termination. So your ability to say that some of your ability to support some of these STARS objectives could increase or help sustain a 3-star rating has significant impact because that organization potentially loses its contract and subsequently its members. Next
Sharon,
slide.
There's two questions actually about
Okay.
the accreditation and the STARS rating. Is
Okay.
there a particular website where you can find out about the accreditation issues, and where can you see the STARS rating for your state or your area?
Okay, those are two excellent questions, and I should have put that in the bibliography. Forgive me.
Maybe
the
you can
first
send
one,
that to me after the webinar.
I can send it to you, but I can just tell you very quickly.
Sure.
If you go to the Joint Commission on Hospital Accreditation's website, JCO, you can. There's like a, I don't want to call it a primer, but there's information on there that explains the hospital accreditation process, goes into detail about how the consumer survey or the HCAP survey impacts and can help you identify. You can also find on JCO what hospitals' ratings are in the JCO system for your local community. As far as the STARS ratings, you can go to the CMS website under Medicare and pull up the STARS rating, and it's capital STAR. You can also use that. Many of your states, your insurance bureaus, will publish the Medicare STAR ratings. Not all of them, but many of them do. So if you go to the Insurance Bureau website or your Department of Health website, in many cases they publish that information. And as well, you can find that information on the CMS website.
Okay, I'm sending it around as we're speaking, so thank you very much.
Very good. I'll make sure I add that to the bibliography. Any other questions before we go to the next slide?
No, I think those are the questions for now. Thank you.
Okay. So we've talked a lot about what their needs are. We've talked a little bit about what are some of the services and supports that you provide. So if you look at, the summary, if you will, their need in your proposal, they need strong, heavy, sustained consumer engagement. You can provide that through your daily contact. You build member trust through the relationship. You help identify hard-to-find members. I can't tell you how many times from a health plan perspective, you've got a senior enrolled in your plan, and when you're doing your health care surveys, which you send out in the mail and the consumer throws in the garbage, you don't know that she spends 2 months of the year with her daughter Dorothy 4 blocks away. And you're trying to reach her because she needs to have some screening or what have you. You know that because you're delivering the meals, and they've told you, send her meal to daughter Dorothy's house for the next 2 months. The nutrition counseling and support that you provide, again, depending on the scope of your agency, are very critical. And again, people who are satisfied with the network that the health plan has providing services tend to rate the health plan overall with a higher rating. One of the other things under the consumer engagement that I'd like to highlight, and I mentioned it earlier, for Medicare Advantage plans, their payment is based on a kind of a capitation rate that's established by actuaries who really are from Mars, who create these tables based on the age, the area, the listing of chronic care ailments, and a number of other factors. So each rate that you get paid for your Medicare enrolled consumers can be very different, but they fit into certain categories. One of the primary categories for an increase in your Medicare rate is how many chronic illnesses and can you document for that client. So somebody who's got a heart condition, has COPD and emphysema, and may have schizophrenia, you get paid a higher rate because it's going to cost you more money to provide care for them. But you have to document that information in your Medicare file. If you don't know, so for those of you who have the diabetes self-management programs, the people you have enrolled in those programs who have identified diabetes to you may not have identified that information to their health plan. Your ability to add that additional data to the health plan's Medicare records can increase their rates. There's a value that you provide through your interaction, your one-on-one interaction with the consumer. Excuse me. Cost containment. Again, you're providing a valuable support and service at what can be a reasonable cost to the health plans. These things help reduce overall utilization of hospitalization, emergency room, and certainly that readmission. You support community-based care versus institutional care. For a number of these dual demonstrations and a number of these other integrated care initiatives, the primary goal is to reduce institutional care. Your ability to provide and collaborate with organizations to support that person in the community helps them meet these overall goals, and there are penalties tied to not being able to achieve some of these deinstitutionalized goals. You complement the clinical services. Again, we understand that the healthcare continuum is about the clinical services, so the diabetes management, etc. But it's also about some of the community supports that are critical to the consumers that both entities serve. And so it gets to that, Solomon's tale of, it's my baby, the baby needs my community-based services. No, it's my baby and the baby needs only clinical services. We can't split the senior in half. We can't split the person enrolled in half. We've got to figure out a way to meld and marry those two critical services to support the overall outcome for the consumer. Quality outcomes, again, your ability to help support, again, depending on the scope of your program, the medication reconciliation, which again is a major factor in the Medicare Advantage STARS rating, the opportunity to identify preventative intervention opportunities, your community needs assessment, which helps provide a baseline of what kind of services are we going to design for our Medicare Advantage or our ACO program in this community. And then your chronic diabetes self-management programs can be a critical factor in helping reduce the diabetics, who tend to be a population with high health care costs and high inpatient utilization. So your ability to be able to demonstrate that those kind of programs, those evidence-based programs, can support their overall quality outcomes is very, very critical. If you think about it, under the C of healthcare integration reforms, your organization's positioning and readiness to collaborate with these new customers will ultimately impact your ability to serve some of your existing clientele and to reach new ones. Your value proposition can provide the leverage you need to kick open the doors to your new and varied partners, these healthcare organizations. Thank you very much.